Are the meeting platform hosts ready to begin?
Yes.
Mr. Chairman, are you ready to begin the hearing?
Yes.
Please provide a 5-second countdown.
5, 4, 3, 2, 1. Good afternoon. I call this hearing to order. A quorum is present. Without objection, the chair is authorized to declare recess at any time. The committee procedures for remote hearings remain the same. If you are experiencing connectivity issues, please make sure you or your staff contact our designated technical support so those issues can be resolved immediately. And if you wish to have a document inserted into the record, please ask for unanimous consent and have your staff email the document to veteransaffairs.hearings@mail.house.gov. Without objection, members will be recognized in order of seniority for questioning witnesses today. This will make it easier for me to ensure all members participating have an opportunity to be recognized. Does any member have a question about the procedures for this hearing? Hearing none, we will proceed. I will now recognize myself for an opening statement. Over the last several years, we have often cited women as the fastest growing cohort among veterans. Our hearing today will examine women veterans' access to the full spectrum of medical care, including reproductive health care through the Veterans Health Administration. Today's hearing also offers an opportunity to reflect on the meaning of freedom. Since the days of the Revolutionary War, women veterans have signed up to fight for and defend our country's founding idea of freedom. And that's why they served, and that's why they continue to serve. But listen closely to my colleagues on the other side of the aisle. It will be abundantly clear. Women veterans' freedom to make choices that are best for their own personal health and medical providers' freedom to exercise their clinical judgment are under attack. Pay attention, too, to the kind of legislation they support. They are so extreme that all but one of our Republican colleagues on this committee have co-sponsored H.R. 1011, a bill that would criminalize women's health care. It would effectively negate women's bodily autonomy once a sperm meets an egg, with no exceptions. The practical effect of this is that women's health care choices become murder, and they have no right to pursue life-saving cancer treatments or use IUDs or emergency contraception. It also takes away the choice of women to pursue science-based family-building treatments, such as in vitro fertilization. Since the Dobbs decision, we have seen a stark contrast between those who claim to be pro-life and those who actually want to defend life, the freedom to choose, and the freedom to respect the right to privacy. Women veterans have worn the uniform of our country with pride, and that is why it is an insult to their service that they would be denied from making the most personal choices about their bodies and their lives. In reflecting on the effect of the recent Supreme Court decision, one of the witnesses on our second panel said in their written testimony, quote, "The moral injury of having served a country to protect our Constitution that has no longer protected me and the ones I love was and still is absolutely devastating," end quote. Fortunately, President Biden and Secretary McDonough are taking bold action to avert imminent and future harm to veterans by restoring certain reproductive health care freedoms that were eliminated in the wake of the Supreme Court's recent decision. 6 days ago, VA published an interim final rule that removes its long-standing prohibition on abortion counseling and authorizes VA medical facilities to furnish abortions in cases of rape, incest, and health of the woman. This ruling is a strong first step that finally puts VA on par with all other federal health care programs. This rule will also promote better equity between the men and women who receive care at VA by removing the gag order on what doctors can discuss with their women patients. No such gag order has ever existed for men, and it is unacceptable that it should ever be exercised against women veterans who served alongside their brothers in arms and deserve the full care they have earned and need. But most importantly, this rule will save women's lives and protect their health. For decades, VA providers have had to call in favors in the community to procure life-saving abortion care for women. Before this interim final rule, pregnant veterans with life-threatening pregnancy complications were turned away. But in the wake of Dobbs, abortion bans have been triggered in multiple states, and community care is no longer an option. Now, VA can provide the abortion care necessary to save women's lives when their communities and states won't. They can save veteran women's lives when their communities and states won't. VA came to this decision after listening to VA healthcare providers and veterans across the country. Congress needs to listen to veterans and providers too. Over the last several decades, I and Health Subcommittee Chairwoman Brownlee, along with several colleagues, including fellow committee members Colin Allred and Ruben Gallego, have been doing just that. Since early August, we have traveled with our staff to 4 different states and the Navajo Nation. We drove more than 1,600 miles, visited 6 different VA medical facilities, and conducted 7 listening sessions to hear from women in each location about their experiences at VA. I came away from these visits enlightened about the challenges VA is currently facing and awestruck by the determination and strength of women veterans. We met with clinical care teams and women veterans program managers like Stephanie in Oklahoma City, Ann in Temple, Texas, Cindy in Las Vegas, and Pat in Phoenix, and VA employees who are serving veterans in creative ways, spending many hours doing outreach and thinking of new ways to show women veterans that VA is a place for them. We have seen what leading in women's health care means, including at VA facilities with dedicated women's clinics with separate entrances, lactation facilities, integrated mental health care, and an overall experience designed and delivered for women veterans' unique needs. And I will tell you that among the VA providers and women veterans I have met with last week, the news of the Secretary's recent regulatory action was met with approval, applause, and hope. We asked, and they answered unequivocally, women veterans want VA to provide the full spectrum of care, where they are fully informed partners in their own health care provisions. There was applause at VA finally joining other federal health care programs and providing life-saving reproductive care, and hope that this critical step is a sign VA is ready to truly welcome women veterans and really provide that full spectrum of care. After one listening session with women veterans last week, a young veteran named Jessica shared her reaction. Quote, "I felt seen, I felt heard, and I felt hopeful for the future of women's health care at VA," end quote. We have also been fielding an online survey to hear from veterans across the country about their experiences receiving reproductive health care, contraceptive care, and infertility treatment at VA. As of this week, we have received over 450 responses from veterans, the overwhelming majority of whom support VA supporting abortion counseling and abortion care in circumstances like those covered by the Secretary's new regulation. So far, 90% of survey respondents have said VA should provide abortion counseling, and 73% of respondents said VA should always or sometimes provide abortion care. This survey is still live on the committee's website, and I encourage any veteran who has tried to access reproductive health care at VA to complete it. Visit veterans.house.gov and click the button at the top to share your story. Your responses will remain anonymous should you wish them to be. I also want to thank Secretary McDonough and President Biden for their courageous and strong regulatory action that will save women's lives, that will save women veterans' lives. I look forward to working with the Secretary to ensure VA has everything it needs to implement this rule successfully. Now, I know much more needs to be done to improve women veterans' experiences at VA, and I see the implementation of this rule as a big leap moment for the department. If implemented well, I have hope that this will attract even more providers to practice at VA and more women veterans to seek care at VA. This is an opportunity to improve the whole spectrum of health care for women veterans. Indeed, while I heard a lot of hope in my conversations with women veterans last week, there was also frustration about long-standing challenges. A majority of women's care is sent out to the community. Caseload for women's care coordinators make it hard and difficult for women veterans to reach their providers and get scheduled appointments in a timely manner. Some VA primary care providers are not as well trained or as committed as they should be in caring for women. Deficiencies in privacy and anti-harassment measures still exist within VA facilities. However, these are all challenges that can be addressed if we collectively commit to doing so. In Phoenix alone, over 11,000 women have chosen to receive their care at VA, and this is a truly astounding and laudable number. It means that we owe these 11,000 women the best experience possible and the health care they have earned and deserve. I am pleased the newly confirmed Undersecretary for Health, Dr. Sharif Elnahal, is appearing before this committee today so that we can discuss with him and others and other leaders on the panel how VHA can truly put a plan into action that will serve women veterans. We'll also hear directly from veterans and women's health providers about their experiences so we can learn more about VA's challenges and develop ways to address them. Women veteran leaders have served this country. It is past time for us to do right by their service. They are watching today and listening to what we all have to say. They are listening closely to who wants to deny them the most basic respect and autonomy, and who wants to support the freedom they fought for. Thank you, and I now recognize Ranking Member Boss for his opening comments. Ranking Member Boss.
Thank you, Mr. Chairman. I appreciate the opportunity today to discuss the care that VA provides to women veterans. But I'd like to start off with a couple stories. You know, I know this young man that's 42 years old. He actually serves as a judge in my hometown. He also is a lieutenant colonel in the United States Marine Corps Reserve. He is an outstanding citizen. He has been a blessing to the people in his community. He has worked hard. He has served this nation. But 43 years ago, a young 17-year-old girl had to make a choice, and about 3 teachers told her, "Don't ruin your life. This is very inconvenient to be pregnant." And she made the choice to keep that child. Now, that child is my son, and that woman is my wife. Fast forward to 20 years ago. My daughter, the day after my son's wedding, matter of fact, came to us, and she had to be rushed to a hospital in St. Louis because she was pregnant with twins. And the twins had what was known as a joint communication. That's a shared umbilical cord. She was 25 weeks along, and if they could just get her to 26, just 26 weeks along, the babies would live. Well, one of the babies, Eliana, died in the womb, causing her to go into labor at 25 and a half weeks. And we held Hallie, where she fought for every breath. And you know, Mr. Chairman, strengthening services to women veterans is a priority of mine, and you shouldn't question that, or anybody else on this panel. You know me. You know that we want to fight for women's rights and their ability to be served by our veterans, or by our VA, to deal with any issue that they might have. Those who honorably have served our country in uniform deserve the best health care and support that we can provide regardless of gender. Now, I've got a granddaughter that just joined the Navy. Now, as a Marine, that's kind of hard on me, but I'll get over that. We tease her a lot about it. But you know, getting the health care that they need, that starts to include support, starts families on their own way. And that doesn't include abortion. I'm proudly pro-life. I believe it is a matter of my faith that abortion is wrong. I also believe, as a matter of law, the VA does not have the authority to offer abortions. Congress made that clear in 1992 by prohibiting VA from providing abortion. 30 years later, that prohibition remains in place. It has not changed. It has not been repealed. It has not been replaced by subsequent congressional action. That's why I am so outraged by the announcement the VA will begin providing abortion to certain veterans and CHAMP VA beneficiaries and abortion counseling to anyone in those groups. This is not only wrong, it's illegal. Let me say it again, it's illegal. The President and his cronies are willfully ignoring the Constitution by acting like laws are mere suggestions. The Biden administration has made a downright habit of it, and it's shameful. It is undemocratic, and it mocks the duty members of Congress have to represent the will of the American people in Washington. With actions like this, the President is doing exactly what he falsely accused duly elected Republican representatives of doing just last week. Following the law isn't an option, it is a requirement. By ignoring the law, VA is violating the wishes and values of millions of Americans who don't want their tax dollars used to pay for abortion at VA or anywhere else. Now, I'm one of those Americans, and the law is clear, and it's on our side here. I'll never stop fighting to ensure that the sanctity of life is protected at the VA and everywhere else. Now, I'm working with my colleagues on the Appropriations Committee and the Senate to consider sanctions against VA for violating the Anti-Deficiency Act. Abortion is not health care, no matter what those on the other side of this issue may feel. The right to life is sacred. American value enshrined in the Declaration of Independence. It's one of the rights service members and veterans throughout history fought and died to defend. I am committed to defending it now for them and for their unborn children. Mr. Chairman, with that, I yield back.
Thank you, Ranking Member Bost. I just want to point out before we begin the questioning that the 1991 law that you cite was superseded by a 1996 law that authorized VA to create its own medical benefits packages, its own package, and that the Hyde Amendment does not apply to VA, and that the Secretary has the authority to create the medical benefits package that characterizes the entire array of services that happens under the VA, the Veterans Health Administration. I will now recognize myself for questions. 5 minutes? Oh, I'm sorry. It'd be helpful if I introduce the witnesses. So the witness panel list. Let's begin. So we have with us today, I'm very happy and pleased to see with us today, Dr. Sharif Elnahal, newly confirmed Undersecretary for Health for the Veterans Health Administration, accompanied by Patricia Hayes, Chief Officer, Women's Health, Veterans Health Administration for the U.S. Department of Veterans Affairs, Dr. Amanda Johnson, Director for Women's Reproductive Health for the Veterans Health Administration, the U.S. Department of Veterans Affairs, and Dr. Julianne Flynn, Acting Assistant Undersecretary for Health for Community Care for the Veterans Health Administration, U.S. Department of Veterans Affairs. Dr. Sharif Elnahal, you are recognized for your opening statement.
Good afternoon, Mr. Chairman, Ranking Member Bost, and members of the committee. I appreciate the opportunity to discuss women veterans' access to health care, including the reproductive health care services available to veterans. I am accompanied today by Dr. Patricia Hayes, our Chief Officer of the Office of Women's Health, Dr. Amanda Johnson, Director of Reproductive Health in the Office of Women's Health, and Dr. Julianne Flynn, our Acting Deputy Undersecretary, Assistant Undersecretary for Health for the Office of Integrated Veterans Care. On behalf of the department, I want to thank this committee for its laser focus and continued collaboration on the whole health of all women veterans. This critical relationship is reflected in the resources that Congress has repeatedly secured for VA and the Office of Women's Health. It is a priority of this administration to ensure comprehensive care for women veterans as seen in President Biden's budget request of $9.8 billion for fiscal year 2023. It is paramount that we continue our progress together with the fastest growing demographic of veterans, women. One important aspect of this work is delivering the reproductive health care services that pregnant veterans need, when they need it, and where they need it. The services we offer include fertility services, contraceptive care, menopause care, maternity care, and life-saving treatment related to pregnancy. But as a result of the Supreme Court decision that overturned Roe v. Wade, certain states have begun to enforce abortion bans and restrictions that create urgent risks to the lives and health of pregnant veterans and VA beneficiaries. Therefore, VA modified its regulations to expand reproductive health care. When medically necessary, VA will now offer abortion counseling and provide abortions when the life or health of the veteran would be endangered if the pregnancy were carried to term, or when the pregnancy is the result of rape or incest. Self-reporting from the pregnant veteran constitutes sufficient evidence that an act of rape or incest has occurred. This expansion is a patient safety decision, first and foremost, to ensure enrolled veterans and VA beneficiaries can access life-saving reproductive health care services at VA no matter where they live. Protecting the health and lives of pregnant veterans is the primary concern of VA. It is important to emphasize that VA is taking these steps with our primary mission in mind: to preserve the lives and health of veterans. There is nothing more important than that. This emergency authority allows us to save lives as we progress toward implementation. As this will be a new service, we recognize that significant steps will need to be taken across the system to implement it. And while a formal implementation plan is under development, I want to note a few areas that we are working toward. For example, we believe medication abortion will be the first available and most common type of abortion provided, so we are working to ensure providers have access to training as well as the needed medications. Pregnancy testing will be required at all VA sites of care, and we must also survey the ability of pelvic ultrasound to assess early pregnancy. Ensuring staffing and necessary equipment is available at sites is critical to providing these services. And in cases where VA is not immediately available to provide needed care, veterans will need to travel to community or other VA sites. In circumstances where veterans normally qualify for transportation benefits for healthcare services that VA provides more generally, so too will veterans qualify for transportation to sites that can safely deliver this care. We will continue to follow existing credentialing and privileging policy requirements to ensure that practitioners who have completed the necessary training and education are permitted to provide abortion services at VA sites of care where these services can be delivered safely. Prior to this expansion of services, abortions and abortion counseling were considered an excluded service in the Community Care Network, or CCN, contracts. The CCN TPA provider agreements will need to be adjusted by the TPAs to allow for abortions and abortion counseling as covered services. During this interim period, veterans' care agreements will be developed and used as a bridge until the CCN contract modifications are completed for these services. Finally, the physical safety of our veterans, providers, and staff is always a critical consideration. Acknowledging the potential divisiveness and emotional response to this issue, VA is alerting security across the system to develop strategies for high-risk sites. In conclusion, the amendment to include abortion services and abortion counseling in cases that threaten the life or health of pregnant veterans or VA beneficiaries reflects our relentless focus on veteran safety. We are committed to providing veterans with access to world-class healthcare and services, including reproductive healthcare, that they have earned through their service to our nation. And VA is determined to stand by that commitment. Mr. Chairman, this concludes my remarks. My colleagues and I are prepared to answer any question that you and your colleagues may have.
Thank you, Dr. Ellen Hall, and it's a pleasure to have you before our committee. I now recognize myself for 5 minutes of questioning. I'll begin with you, Dr. Ellen Hall. Your most recent employer was a non-VA community hospital. Based on experience and your knowledge about the state of reproductive health care access in this country post-pandemic and post-Dobbs. Can you tell us a little about the capacity of community providers to care for pregnant veterans and to provide abortions, and how that influenced VA's decision to issue last Friday's interim final rule?
Thank you, Mr. Chairman. I indeed led a hospital in Newark, New Jersey. That is a state that does afford these services, permit these services, I should say, to women across the state. And so there are ways for veterans to get that care outside of VA in New Jersey, but that simply is not the case across the country, especially after the Dobbs decision. Part of the emergency that we are responding to is related to the fact that states have leveled restrictions, certain states across the country, in terms of access to these services. And in many of those states, the baseline availability of reproductive health care services was much less than it is in other parts of the country, including New Jersey. And so we, between 10 to 20 cases of veterans a year that our Office of Women's Health has told me about, we have had to actually send our veterans for life-saving care to community facilities, ask them to do these services to save veterans' lives, and then come around and say, we can't pay you for these services. And so, given that the baseline availability of these services was variable across the country, and certainly more limited in certain states, we could not contend with the safety environment after the Dobbs decision in terms of the restrictions to these services, state by state.
These 10 to 12 women veterans that you speak of, more or less per year, these are women veterans who are facing life-threatening health conditions. Is that correct?
That's right, Mr. Chairman.
And for them to not be able to have the option to seek an abortion procedure because it's not available at the VA because of the rules that we had in place, their lives are in danger, or were in danger.
In these cases, yes, Mr. Chairman. And also, we were particularly concerned about the environment after the Dobbs decision, whereby some states are restricting these services even more than they were before. And we could simply not contend with that environment of safety for veterans. And another point I want to mention, Mr. Chairman, is that we feel that this is needed care, especially in this context. And as a general matter, if these veterans are under our care, and we know that we can save their lives, we have to do it.
And under the previous regulatory environment, a VA practitioner theoretically was not even able to talk to a woman veteran about a procedure that could save her life. Is that correct?
That's correct, Mr. Chairman.
To what extent are community providers overextended, and what is the effect of health system consolidations and hospital closures on veterans' access to life-saving care?
Having led an institution outside of VA recently, I can tell you that access to healthcare services more broadly is being strained across the country. And I can tell you that the wait times for a lot of critical pieces of the care in the hospital that I was providing were strained not only by new and evolving public health issues as we proceed into the endemic phase of the pandemic, but also the fact that we were catching up to delayed and deferred care as a result of the pandemic. And so those things are layered upon our concerns in VA for access to these services outside of VA. And part of that led to our decision to say that we have to respond to this emergency and offer these services to women veterans across the country.
And Dr. Anhal, we can anticipate, I mean, just knowing the data of annual needs that arise of 10 to 20 women veterans across the country who face life-threatening pregnancies. We can anticipate that each succeeding year, we're likely, given the numbers of veterans, that that we would see 10 to 20 veterans, women veterans, facing life-threatening situations going forward each year. That's a reasonable prediction to make, right?
Well, it's true, Mr. Chairman, that this is the fastest growing veteran demographic that we have. We have hundreds of thousands of women veterans of childbearing age. And so I think if those trends continue, and we very much expect them to, you may see even more of those veterans requiring life-saving care. Yet another reason that this is an important move.
Well, my time is up, but I certainly see, I want to confirm and validate to you the basis of this, the evidence of the emergency, and I commend you for taking decisive action along with the Secretary. I now recognize Ranking Member Boss for 5 minutes.
Thank you, Mr. Chairman. Dr. Ellenhall, if you would, please respond yes or no, and only yes or no, to the following questions. First, yes or no, did Congress expressly prohibit VA in law from providing abortion in Section 106 of Public Law 102-585?
VA's interpretation of that law, sir, is...
No, yes or no? Your answer is no. Well, it's actually yes. The true answer is yes, because that law was passed. You're not using that law to try to undermine this one. Okay, that's second. Yes or no? Was Congress ever expressly repealed or prohibition in the law?
I'm not aware of that,
The answer is no.
Congressman.
The correct answer, of course, in all of this, Congress did prohibit VA from providing abortion services in 1992. That prohibition has never been repealed, even though some comments have been made that you're using another twist on a different section of the law to try to get there. So it's still in law today. And where I come from, we try to follow the law. And it disturbs me that one of your first acts as Undersecretary for Health is to disobey the law so blatantly, especially on an issue that is quite literally a matter of life and death for the most innocent, helpless, and defenseless among us, that the previous administration of both parties have been declined to pursue in the absence of a legal mandate that the VA certainly does not have today. My office sent a series of questions, detailed questions last week about how VA would operationalize this rule. My questions should have been fairly basic ones, and we didn't get answers back until yesterday. But, for example, we asked if VA planned to allow late-term abortions for women in their third and final week of pregnancy. Third trimester and final week of pregnancy. We asked if the VA would perform abortions on minors in camp because of CHAMP VA, and if so, if the patient or if the parental consent or notice would be required. We ask how VA providers with moral objections would be excused from providing abortions, counseling, or performing abortions. VA blew past the questions deadline to respond to our questions. When we did receive the answer to my questions, as I said late yesterday, many of the responses were non or half answers. Setting aside the basic illegality of this effort, how can you justify proposing such a significant change without being able to provide timely responses to basic questions about it? Doctor? And then I'm going to ask this question as well with that. All you've talked about so far with the questions that came up earlier is about emergency situations. Your proposals and what you've answered us goes way before past emergency and also passes well past the Hyde Amendment. So do you have a response?
Yes, Congressman. I understand that you are taking this position around our authority, and I want to say that we respectfully disagree with that. Our consultation with the Department of Justice. What I can tell you is that when we were trying to be responsive to the urgent situation that faced veterans across the country after the Supreme Court decision that overturned Roe versus Wade, What we wanted to do was ensure that our clinicians could exercise their judgment without having to take extra steps to determine whether something they felt was needed to preserve the life and health of veterans. We wanted to make sure they were free to exercise their clinical judgment to ensure that veterans' needs were cared for.
So then you're admitting that it does go a lot further than just emergency situations.
We trust our clinicians, Congressman, to make the right decisions for veterans.
Can you
And
answer
that
what I
is our-
said? Your decisions and the way that you're putting the rules together goes much further than just the safety of our veterans?
I think all of it has to do, Congressman, with the safety and health of our veterans.
Let's go with one of the questions that I asked, and I'm already over on time. Okay. I would like to just find out, so at first we got a verbal answer on if a clinician, for moral reasons, wants to not perform this. And the answer verbally was yes. Then the answer that we received was, well, each case would be weighed out whether or not they would have that. I think that there's a lot of issues that you're going to have with this across the spectrum. And more than this hearing is going to take to figure out where we're going with this. And the question of legality, I think, will probably be found out in the courts at some time. So with that, I am out of time. I yield back. Thank you, Mr. Chairman, for letting me go over.
Thank you, Ranking Member Bost. I now recognize Chairwoman Brownlee of our Health Subcommittee. Chairwoman Brownlee, for 5 minutes.
Thank you, Mr. Chairman, and thank you all for being here. Dr. Elnahal, thank you for our previous conversation earlier this week. I was glad to be able to have a longer conversation with you on this issue, and I certainly thank you and the Secretary for moving forward with this important rule and service within the VA, and I applaud the fact that the way you describe it is not just life, but for the health of the woman veteran. So I think that is very, very important. And I will say in response to Mr. Bose, some of Mr. Bose's comments, albeit I respect his position on this. My problem is I don't think he respects mine, but I certainly honor and respect his. But I think it's more likely that VA will find many, many more than 10 or 12 women a year requiring emergency or life-saving abortions because up until this point there was a VA gag rule. And VA providers couldn't even discuss abortions with veterans experiencing, sometimes major complications in their pregnancy. So I think it will be more, and I think we will save more lives as a consequence. I do want to say that I will continue to advocate that I believe a woman's right to choose and make decisions around her own body should be a part of the overall health care provided by the VA, and I will continue to advocate for that because I feel very, very strongly that it is what the right thing for the VA to do. So, having said that, I wanted to go and ask. First of all, to Dr. Elnahal, if there's anything you need from us in terms of trying to execute this rule, if you need something, a decision by Congress and so forth, I hope you'll speak with us and let us work as a team. I did want to ask Dr. Johnson a question because the last time we discussed my Veterans Infertility Treatment Act, it was at a legislative hearing, and it was 2 days before the Dobbs Supreme Court decision. Now, in a post-Roe world, I believe it's crucial that we make IVF care a part of the VA medical benefits package, unrelated to a service connection, marital status, gender identity, sexual orientation, race, or ethnicity. So, Dr. Johnson, do you consider IVF to be part of essential health care?
My apologies. I think family building services are part of essential health care. I think it follows our responsibility to promote, preserve, and restore the health of the veterans who've served our country.
Very good. Well, Dr. Elnahoff, this is something, too, that I want to work with you because, again, I think this is putting our right foot forward. As you said in your opening comments, women veterans are the fastest growing cohort within the veteran community. I think we can all recognize that we have a ways to go to bring equity to services for our women veterans. We've made some strong steps, but we have many more steps to go. And particularly in a post-Roe world now, I think it's important, as you have thought about access to abortion in the event of life, health, rape, or incest, I think it's also important that we look at a full benefits package and including IVF without a service connection barrier to it, that it is just part of a woman's health care. If you want to make a comment, I would love to hear it.
My thoughts align with Dr. Johnson's exactly on this. I think part of the reason that we lag among women veterans in terms of trust has to do with not only what you mentioned around these previous restrictions on being able to discuss the full scope of reproductive health care, but also the services that follow that. And so I look forward to working with you, Congresswoman, on this.
Thank you very much. And last but not least, with a second to spare, is I know in the second panel and reading the testimony of the second panel, there's strong consistency and a message that it goes through all of those testimonies to say still that the VA is generally not an open, inclusive place for women, to walk into and be served without harassment. And so we've got to continue to work on that. And I know the Deborah Sampson bill took a big, giant step in that direction, but we need to make sure that it is executed and scaled across the enterprise. As you said in your testimony, it's unacceptable otherwise. I sent a letter yesterday to the Secretary regarding the motto. And the motto is not going to, change overnight the culture of the VA, but I think it is a first very important step to really signal and communicate to our women veterans that we respect and are grateful for their service to our country. For the LGBTQ community, we are grateful and recognize their service to our country. And I think the motto would be a long way in going to say the VA is very much committed to inclusivity. Thank you very much. I'll yield back, Mr. Chairman.
Thank you, Chairwoman Brownlee. I now recognize General Bergman for 5 minutes.
Thank you, Mr. Chairman. Today is a unique day for a lot of reasons, and I'm going to start with it's 54 days before an election. I was very uniquely surprised by the little slideshow in your opening remarks. In the military, I don't know whether there's a Robert's Rules of Order for this, but in the military it'd fall under Article 133, which is conduct unbecoming. I would suggest to you that the slideshow is not something to be used in a campaign commercial. That's just a personal viewpoint of how we open this meeting. I would also suggest, as a correlation to that, conduct unbecoming goes to all levels of leadership. And the two Marines standing behind President Biden in the speech a couple of weeks ago in their dress blues, that was conduct unbecoming. Now let's get to the point at hand. Dr. Elnahal, VA's response to questions from Ranking Member Boss to state that the VA will allow mental health providers to provide abortion counseling and abortion services to veterans. Yes or no?
Yes, Congressman, they would be part of a number of types of providers who would be doing
Yeah,
this.
but mental health providers,
Yes.
okay. Are VA mental health providers trained in obstetrics, maternal health, how to conduct, an abortion procedure or the risks of such a procedure?
Well, Congressman, I think.
Yes or no? Are they trained? In the military, we don't send anybody into, because we're talking about veterans here. We don't send anybody into a billet to ask them to do something that they're not trained to do. Are these people trained? They're mental health counselors, and they're probably very good, but are they trained? Yes
Congressman,
or no?
they are trained in discussing clinical options for care, and they are often.
So who, okay, if they're,
primary
okay,
providers.
if they're trained in discussing clinical options, who provides the expert opinion to that veteran sitting there right with them who may or may not understand what the options are? What is the training that's going to be given to the people who work for you to be able to provide that veteran with a really realistic, risk-assessed decision for them? What's the plan?
It's a fair question, Congressman. We have great programming that Dr. Hayes can speak to on comprehensive training in women's health across multiple sets of classes of providers.
I'm talking about specifically mental health providers talking to women, veterans, who are already under a great deal of stress. Your mental health care providers are trained to deal with that stress. But who is going to be the subject matter expert sitting with them when that veteran has a question? Have we laid that out? Is there a plan? Can we see it?
The plan for how this will be best introduced in order to make sure that we put the veteran at the center of this decision would be that we will conduct training. But first, I think it's necessary to understand that what happens is someone gets a positive pregnancy test from their gynecologist or their primary care provider.
You're missing the
No.
point. You've got people on your staff, mental health providers, who are going to provide this. We're not talking now about the veteran who has a result of a pregnancy test or whatever it is. We're talking about the people that you train and deploy to help these veterans who are under stress. What's the plan?
Yes, sir. They would be, the mental health counselor would be only part of a team that would be working with a gynecologist.
So are they all going to sit in this counseling session?
They may well all be there as part of the way.
Well, when
that
they
we
may
put-
well, I mean, again,
be.
if I'm under stress in a situation and I've got someone advising me, I want to make sure that I can get answers right then, right there. Is this going to be one of these things where we kick the can down the road, come back next week, whatever, because I'm not qualified to answer your question? Is there a plan? Can you,
We cannot provide the plan exactly today. Because
okay, I would
we're in the
suggest let's keep the cart behind the horse and let's get the plan together before we start putting women veterans at risk for making a decision that they could later regret because they got bad information. With that, I yield back.
Thank you, General Bergman. I just want you to know that this same committee will gather 2 weeks from today to hold a hearing on veteran suicide prevention. I will not entertain for 1 second any claim that mental health is not health. We know that mental health challenges are, of course, related to sexual trauma, and they also occur with wanted pregnancies and pregnancy complications. In VA's testimony today, Dr. Elno noted the horrible statistic that nearly 60% of pregnancy-associated deaths among women veterans in VA care were related to suicide, homicide, and overdose, and that mental health conditions affected 78% of pregnancies among veterans who died in pregnancy-associated events. These statistics are horrendous, but they reflect very real dangers for very real women, and many of you may not know that interpersonal violence can get as much much worse when when a woman becomes pregnant, and so that suicidal thoughts and behaviors also accompany that. Pregnancy is a risk factor for violence. And obviously, a reasonable person can understand that mental health considerations are every bit as important as physical health factors in weighing decisions. Pregnant veterans and their clinicians must be able to consider and make decisions on the basis of all health factors, full stop. I now recognize Representative Underwood for 5 minutes.
Thank you, Mr. Chairman. Earlier this summer, Americans lost a constitutional right for the first time ever when the extremist Supreme Court overturned Roe v. Wade. Republican governors and state legislators have been working for decades to impose extreme laws banning abortion, and now they're succeeding, sometimes without exceptions even for rape or incest. That's why it's so important that VA has taken a critical step in the opposite direction this month, finally providing veterans with access to abortion counseling and abortion care in cases of rape, incest, or when the life of a pregnant veteran is endangered. As a registered nurse, I applaud this rule from the VA, which is grounded in medical evidence and is critical for patient safety. Dr. Elnahal, in announcing this rule, you said that the VA came to this decision, quote, after listening to VA healthcare providers and veterans across the country who sounded the alarm that abortion restrictions are creating a medical emergency for those you serve. Can you share some of the stories you heard from veterans and VA healthcare professionals that underscored the need for this policy?
Absolutely, Congresswoman, and want to start by saying thank you for your advocacy and your work on maternal mortality, particularly for women of color. That is a priority that we share as well. Dr. Hayes and Dr. Johnson led those discussions with our clinical teams. I'd like to ask them to weigh in.
Great.
I think it's important to understand that the way in which we work very individually with veterans is at the heart of this matter, that we need to be able to talk with veterans, to talk about their personal response to their own pregnancy test, and be able to go with that in terms of what do they need. Mm-hmm. The kinds of things that we encounter then are these one-to-one tragic situations often where a person has to make that decision for themselves about their own life-threatening medical conditions and the pregnancy that they have. And so it's a one-to-one kind of situation. We could give detail after detail, but most importantly is it's an individual veteran who is in this situation that we need to be able to help at that point to preserve her life, to restore her health.
Thank you very much. Dr. Elnahal, we know that bad actors are spreading false information about reproductive health, often deliberately, with the goal of discouraging abortion or limiting access even further. How is VA planning to prevent and combat disinformation and misinformation around this rule?
Well, I think, Congresswoman, the discussions that our providers can now have about abortion services as an option to veterans is, I think, the most important and significant opportunity to dispel any misinformation or misunderstanding about these services, their risks, their benefits. And I think a lot of that will be borne out in the latitude that our clinicians now finally have to be able to have these discussions. I don't know, Dr. Johnson, if you'd like to add to that from your experiences.
No, I completely agree with you. I mean, I think what we strive to do and what we do well is practice evidence-based medicine. And so part of that is the care that our providers provide to veterans, and it's also part of the communications that we develop for veterans directly about the care and their options for care that they receive.
Excellent. Well, I encourage your office to be in close touch with those communications professionals within the VA and with your outreach team that does the great work with the VSOs. That is an opportunity to make sure that the veterans that you serve understand the facts about this rule and this rule change. Okay. Have you seen a lot of confusion around what's legal and what's not in the wake of Roe being overturned? I'm sorry, we have also seen a lot of confusion about what's legal and what's not in the wake of Roe being overturned. What actions is VA taking to proactively communicate with veterans to ensure they're aware of the reproductive health services for which they're now eligible?
I think the dynamic you're describing, Congresswoman, was a big factor in our assessment of the risk after the Supreme Court decision that overturned Roe versus Wade. The degree to which these services can be provided in states with restrictions vary. You have some states, for example, that have this affirmative defense mechanism for clinicians, which essentially means they have to be charged with a crime in order to justify their clinical decision. And so that weighed in heavily in our assessment of risk against these state laws. I think more generally, we are going to be communicating as much as we can across our population of women veterans about the availability of these services and the parameters by which our clinicians will offer them.
Dr. Elnahal, in your testimony, you described plans to strengthen VA's maternity care coordination programs. As you know, I was proud to lead the bipartisan Protecting Moms Who Served Act, which was signed into law by President Biden last year and provides new funding for initiatives to eliminate preventable maternal mortality, morbidity, and disparities among pregnant and postpartum veterans. How will these investments enhance the care and support provided to veterans during and after their pregnancies?
We really thank you for that legislation, Congresswoman, because it does allow us to expand our efforts in this really important clinical area. And I'll ask Dr. Johnson to describe that in more detail.
Thank you. I echo Dr. Elnahal's gratitude for the Protecting Moms Who Served Act, but primarily what our goal is to strengthen our and expand our maternity care coordination to the 12 months postpartum, which we know is a vulnerable time for families,
Yes.
particularly in areas of perinatal mental health, intimate partner violence, food and housing insecurity. In addition, we are looking at targeted ways to intervene for those veterans who are most at risk for complications of pregnancy. So, for example, veterans with PTSD, veterans with hypertensive disorders or risk factors for severe preeclampsia, just so that we can further support pregnant people.
Thank you for your testimony today. I yield back.
Thank you, Representative Underwood. Mr. Rosendale, I recognize you for 5 minutes.
Thank you, Mr. Chair. You caught me off guard. I thought I was going behind Representative Pappas. As each of you have been sent here by the administration, which is the most pro-abortion administration that has ever been elected, quite frankly, I have no questions for you. I'll only make a statement. Millions of Americans have relied upon the Hyde Amendment and the Veterans Health Care Act of 1992 to be assured that their tax dollars would not be used to fund abortions, abortifacients, or abortion counseling services. They felt assured because it was in law. And now the Veterans Administration and a bunch of unelected bureaucrats who don't have to answer to the voters of this country have passed a rule. And I am sure that we all in this room understand the difference between a rule and a law. A rule to supersede the rule of law and use taxpayers' dollars for abortions, abortifacients, and abortion counseling. It's my understanding that the state of Alabama has already filed a lawsuit to stop this overreach of power by the Veterans Administration. And quite frankly, I look forward to it being overturned by the courts, and I plan to do whatever I can to support that effort. I yield back.
Thank you, Mr. Rosendale. I will now recognize Chairman Pappas for 5 minutes.
Thank you, Mr. Chairman, and thank you to our panel for what you're doing to meet the needs of our women veterans. And I just want to mention a project in my district. The Manchester VA Medical Center is continuing construction on a women's health clinic, and it's slated to open in 2023. I know our veterans are looking forward to that. And it's going to go a long way to providing high-quality, equitable health care for women veterans in an environment that suits their needs. We know that a key barrier for women veterans, which they've cited in accessing gender-specific care at VA, is a poor experience of general safety and comfort with the environment at VA facilities. And in accordance with agency policy and other standards, VHA requires its facilities to follow certain standards related to the environment of care for women veterans. The policies specify privacy, dignity, sense of security, and safety considerations that all clinical spaces in VA medical centers must meet. So to ensure compliance with these standards, VHA directs VAMCs to conduct regular inspections. But VA relies on facilities to self-report their compliance. GAO found in its two most recent reports on women veterans' health care that facilities don't always accurately self-report information about their compliance with the standards, and VA lacks a mechanism to independently validate facilities' self-reported compliance. So maybe, Dr. Hayes, I could ask this of you. What oversight and accountability mechanisms exist for VA to validate the accuracy of facilities' self-reported data?
Congressman, thank you. I really appreciate the major concern that you voice about the veteran experience, the woman veteran experience in walking into a VA. We have been concerned about the harassment. We have a major focus because the level of harassment of our veterans, male or female, is unacceptable. And we're going to continue to have that effort be foremost. When you talk about the environment of care, you're absolutely correct that there is a self-report. We have done two things in the last year. One is firm up the policy and publish the policy about what must be, again, required to be at each facility. And that is matched now with what is the walk-around tablet-based survey. And those tablet-based surveys are now looped up to a higher level. And we will continue to have those reported at the VISN level with deficiencies noted.
Terrific. And maybe I could say with you, Dr. Hayes, despite the growing number of women veterans who are utilizing VA healthcare, we know that only a minority of them choose to receive their gender-specific care at VA. Again, some of the issues that you've already covered are barriers, and I want to commend VA for its campaign to assign designated women's health primary care providers, or WHPCPs, to at least 85% of women veterans. These are critically important to ensure that VA can provide quality, accessible, gender-specific care to women veterans at its facilities. But many women veterans have expressed to the committee that they lack the confidence in the clinical competence of these WHPCPs, particularly for whom women's health is not their focus or specialty. So I'm wondering if you could address that and share any oversight and accountability tools that VA is utilizing to monitor this situation.
I'm actually concerned if you say that, as you found, that women veterans are saying they're not confident with the competency of their women's health providers. We do conduct significant training. We just surpassed this week, yesterday and today, having trained 10,000 of our women's health providers specifically in gender-specific care. And we put it as a very high priority that folks not only go through the training, but continue their competencies through continuing education and practice by seeing a number of women veterans. So I want to make sure that we reassure you that we're focused on the competency and the fact that our women are actually reporting high satisfaction and high trust and comfort in our care. So I'd like to work with you on your concerns there and see what we can do to meet any additional gaps that are being identified.
Well, maybe we can continue to communicate, and if there are details about specific cases, we can relay that to you. But just to reiterate, after an additional training, there are refreshers and there's continuing education that's provided?
It's not only provided, but required for them to be continued to be a women's health provider.
Okay.
And we do monitor that yearly.
Thank you for your responses. I yield back.
Thank you, Chairman Pappas. I now recognize Representative Miller Meeks for 5 minutes.
Thank you very much, and I thank our panel for being here. I'm a physician, and I'm a veteran, and a female veteran. And I'm somewhat confused by some of what I'm hearing here today. So if I understand this correctly, the VA feels that it has to make a rule that violates law that has been passed by members of Congress, who the public feels is the body that makes laws, because the urgency of the Dobbs decision and the potential for state laws restricting abortions for life-saving emergency care of women. So exactly how many states prohibit abortions in the life of the mother?
Congresswoman, the concern is
exactly how many states prohibit abortion for saving the life of a mother? I'm assuming you've researched this, since that's the reason for your rule.
It is not just permissiveness, Congresswoman.
So you
it is
don't
the
know the answer to that
practicality
question?
of
Would that
getting-
be fair to say?
Of getting women
Thank you.
to the care that they need in those states, and that is what is of concern.
You also said that these are life-saving procedures, and in what trimester of pregnancy were these life-saving procedures conducted for the 10 to 20 women, female veterans that contacted you?
It certainly varies, Congresswoman. I'll ask Dr. Hayes if she has a summary of that.
Well, certainly, I think you need to understand that the types of...
What trimester, please?
No, ma'am.
Do you not know the trimester?
We do. I'd
Okay,
like to
thank you.
explain.
And you also said that mental health providers would be able to provide counseling. So do mental health providers, do they discuss cancer care with veterans, either male or female? Do they discuss cataract surgery? And I've performed surgery in VA hospitals. Do they discuss joint replacement? Some of these, I'm sure, veterans that are having their joints replaced or cataract surgery also have mental health issues. Do they discuss hysterectomies? Do they discuss cancer treatment, mastectomy, chemotherapy, and radiation therapy for breast cancer patients? Are they involved in counseling of these patients?
Congresswoman, the multidisciplinary care model that Dr. Hayes and the Office of Women's Health have implemented across the spectrum for women's health care does include mental health providers.
So you have mental health providers in your continuum of care. Mental health providers are giving counseling for all of these issues?
As you know, Congresswoman, these are often
It's a simple yes or no. Are they involved in counseling for all other types of care for women veterans or for male veterans?
they're certainly involved, Congresswoman, with sensitive discussions on the gravity
So
of
only
these
sensitive
decisions.
discussions. You also said that you've had an approach of 10 to 20 female veterans who needed life-saving abortions. And so I'm expecting that you think that this would be limited, the numbers of abortions that would be performed.
We project, Congresswoman, that about 1,000 women veterans a year would receive
And
this service.
you know, there's medical research and medical literature that the more procedures one physician does, the better quality of care they deliver. So do you think that if 10 to 20 or 1,000 procedures are performed in a year in the entire United States, in the entire VA system, that they will have the level of expertise that they need to provide women quality of care? Because if I were that woman veteran, I would ask the same thing that people ask me of cataract surgery, which is how many have I done? How many have I performed? In what trimester have I performed? Do I have the expertise and knowledge in order to perform that? So I would be extremely concerned as a female veteran to be approaching a VA facility to be counseled by a mental health provider, even in your continuum of care, for a provider who has performed very little procedures. My personal viewpoint is that there are exceptions for rape, incest, and the life of the mother, but I think for the VA to go on a rulemaking tact against the wishes of Congress and the public is unconscionable. Thank you. I yield back my time.
Thank you, Representative Miller-Meeks. I now recognize Representative Allred for 5 minutes. Mr. O'Neill.
Well, thank you, Mr. Chairman, for holding this critically important hearing. My home state of Texas has the most women veterans of any state in the country, and it has one of the nation's strictest laws banning abortion from the moment of fertilization, with only a narrow exception for the health of the mother. This is a law that was written in 1925, and that came into effect after the Supreme Court's recent ruling. So that means that every Texas woman veteran, where we have the most of any state in the country, who is raped, women who serve our nation, who is raped and has a pregnancy as a result of that, would be forced to carry that pregnancy to term or find a way to leave the state if the VA weren't able to offer this care. It means that every Texas woman veteran whose life is in danger because of a complication with their pregnancy, which in your testimony you note that veterans are at greater risk of experiencing pregnancy-related complications due to increased rates of chronic health conditions, that everyone that has a complication would be subject to the legal whims, basically, of some of the hospitals or places they may seek care. This is not a hypothetical scenario. There are Texas women who've been turned away with life-risking conditions because the hospital was worried that if they provided this care, that they would be subject to criminal penalties, a felony, in fact, under our 1925 law. That's why I support the VA's decision here. It's a decision that's in the best interest of protecting our women veterans' health, both physical and mental. And I want to talk about how this law will interact with our laws in Texas. I appreciate that the IFR clarifies that VA healthcare professionals are preempted from state and local laws surrounding abortion as it's a federal agency. But in states like Texas, where providing abortions is a felony, and there's a possibility of being sued in addition for providing them, do you anticipate VA providers may still have concerns about their liability when providing care to patients? And how does the VA intend to address those concerns and make sure that providers are comfortable providing abortion services to our women veterans?
Congressman, it's a good question, and we do anticipate that, which is why we are trying to clarify as much as possible how federal supremacy plays into this, and the fact that when these clinicians are doing their work on federal property or are referring veterans for care in the community, we are doing so with the authority of federal law, which is enforced by this IFR. And so we will do everything we can to make sure we communicate that they are protected and will be protected by the federal government.
Yeah, and I do want to talk about community care. We know that many women veterans receive their gender-specific care, as you mentioned in your testimony, in the community. You state that the VA will pay for abortion counseling or services from providers in the community where available. Now, in states like Texas, where abortion is banned and abortion providers have been driven out of offering care in that state, how does the VA intend to make sure our veterans have access to community providers that can offer abortion care?
Well, it's correct, Congressman, that community providers in states where there are restrictions will not be available to treat our veterans because of those state laws. And so that is why, by adding it to the medical benefits package, we are making clear that benefits such as travel to sites of care where they can get this necessary care will be offered by VA where it is offered for any other type of service and where they otherwise qualify. And that's the strength of adding it to the medical benefits package, which is clearly under the Secretary's authority.
Well, I agree with you. I think that's a really important point. The cost and difficulty associated with having to do the travel yourselves is often prohibitive for many women. And I would just want to really quickly, in the minute that I have left, just address how we're going to inform our Texas veterans about these services and what the VA plans are for outreach in this case, and how we can ensure that they know they have access to these services.
It's a big priority, Congressman, to make sure that we communicate as far and wide as possible to our women veterans the services that are available and new and being offered as a result of this IFR. And if my colleagues in Women's Health Office want to comment.
We do very much know that it's very important to have us messaging out to veterans. We ask a little leeway because this is the 6th day that we've had the ability to discuss this publicly and be able to get messaging out, and we're very clear that we need to get this rolling for veterans. We want to make sure the information we get out is correct and have also in place the access that they will need. If we send the information, we want to know how they can get the care they need.
Yeah. Well, thank you for your testimony. In states like Texas, women's lives are absolutely at risk because of a 1925 law that's in place, because of the extremely narrow exceptions that are in place, because of the fear that if you provide these services, you could be facing a felony or be sued. And so that's why it's so important for Texas women veterans that you offer this, and I want to thank you for reaching this decision, and thank you for your testimony.
Thank you, Representative Allred. I now recognize Representative Elsie for 5 minutes.
Thank you, Mr. Chairman. The question came up from Dr. Miller Meeks about which states prevent or prohibit abortions in the case of the mother's life is at risk, and there are no states that do that. There are no states that do that. So please don't continue to use that framework as a reasoning for this. It's disappointing to see. So, Dr. Elnahal, have you considered the possibility that this rule will put healthcare providers and the administrators overseeing its implementation in legal jeopardy, both criminal and civil, for violating federal and state laws? Yes or no?
Well, Congressman, there may be attempts from state to state or by other jurisdictions to do that. And so what we are trying to do is make clear that our authority under federal supremacy, which is a constitutional authority, as well as the Secretary's authority under the medical benefits package with this emergency rule, protects those clinicians, and the full force of the federal government will be there for them.
I thought you'd say that. All right. Describe for me and the American people in medical detail the procedure by which you are now allowing a VA facility to end the life of an 8.5-month-old unborn child. Describe in medical detail, please, whoever is qualified to do that at this forum.
Congressman, The services that we will be providing under this rule, by definition, in the language of the rule, are in place to protect the life and health of the veteran.
I can see
That
that
is our
that question is
mandate.
not going to be answered, so I'll be happy to accept your written answer for the record. Thank you, Doctor. In the case of medical emergency, the VA would be permitted to provide medical services to non-VA beneficiaries, including abortion counseling and abortions where VA's criteria were met. For those who don't understand what's actually happening here, this is a workaround for Dobbs and for the individual states, which only sent it back to the states. Dobbs sent it back to the states. And this is a workaround for the federalization, using the VA as a mule, to legalize abortion paid for by the federal government, knowing that the VA is not beholden to the Hyde Amendment. I think that's pretty cynical. And I look forward to appropriations language next session, which will further clarify that. But I think overall it's the vague language that you were referring to in 1996 doesn't say anything about abortion, but the 1992 law is very specific about abortion. If somebody wants to repeal the law from 1992, they're going to use very specific language, and that was not done here. And I'll leave the rest of my time, but this seems pretty cynical on the part of the VA. And as a veteran of 20 years who cares for my sailors, soldiers, and airmen and Marines that I led into combat, that nobody is being prevented from receiving medical care under the VA. I'm very proud of what we do in this committee. I'm very proud of what the VA generally does. This rulemaking is yet another example of this administration using unelected bureaucracy to make law where it has no power to do so. I yield back my time.
Thank you, Representative Elzey. I now recognize Representative Frankel for 5 minutes.
Thank you, Mr. Chair. And let me start by thanking you and Representative Brownlee and the department for your efforts to advance abortion counseling and care for veterans. And I think I speak for the majority of Americans when I say a woman should be in charge of her own reproductive health care, her future, her life, and that medical decisions should be made by a woman with her doctor, not by politicians, especially politicians who have no idea of the circumstances of her life. And I'll just say simply that abortion is part of health care. And, it's sort of, today I believe in access, obviously, to full reproductive care for all women. Today we're talking about women veterans. And think about it. Some of them willing to risk their lives. They were there standing up for our freedom. Don't they deserve their freedom? And isn't that what we're talking about? The freedom of women veterans to determine their own future? So thank you, thank you, thank you. Representative Aldred had some questions I want to follow up on, just in terms of how this thing gets implemented, because the concept to me is the right one. The package, the benefit package now, does that mean that the VA will pay for counseling and for abortion care for all veterans?
So, Congresswoman, abortion counseling will be made available to any veteran, and abortion services would be limited to situations clinically where the life or health of the mother would be put at risk if they carried to term, or in cases of rape and incest.
Okay, and that I'm assuming that is up to a doctor's determination.
Yes, ma'am.
Okay, and I'm from Florida, so like Representative Aldred, I have to deal with a very oppressive, autocratic governor and state legislature that think they should be in charge of women's lives. And I think they would do anything to try to, to put obstacles in front of this new policy. Under your program, would a woman be able to go, and a doctor would be safe from the legal restrictions at a VA clinic? What about at a private doctor's office that is doing work for the VA?
Well, Congresswoman, where you have our federal employees doing clinical work on our property, VA property, they would be protected under federal supremacy, and the full force of the federal government will be there for them should they be challenged on that. When it comes to community providers, those protections would not necessarily be available. And so that is where we have to factor in with our implementation plan ways that we can deliver care to those veterans in those states, including possibly transporting them, should they qualify for travel benefits under our medical benefits package more generally, to VA sites or community providers that can do this work.
Yeah, I think that's especially going to be challenging for women who live in states like in Florida. If you live in Miami, Florida, you know, the next state that allows abortion care is literally hundreds of miles away from Florida. And you probably find that around the country. You know, there's certain parts of the south part of the country, parts of obviously the Midwest, women who live in rural areas, those are all going to be problematic. So I hope you're going to really focus in on that. And I have 46 seconds to ask one more question, which is, is contraception now going to be fully paid by the VA or still requiring co-pays?
I'll defer to Dr. Hayes to answer that question.
Thank you. The contraception copay is still in existence. We can give you additional details of how that runs under the regulations and why that is still pending within the VA. We did submit a supportive legislative request to have contraception copays removed.
All right, I think that's a good idea. Does it have to be done by the Congress, or can your department do that?
I think that's best handled in a written response to outline for you how exactly that might take place.
Okay, and may I just respectfully suggest that that's a good idea to get that done. Thank you. I yield back. Mr. Chairman, that's another initiative for you.
Mission accepted. Thank you, Representative Frankel. Mr. Boss, I'd like to go through a second round of questions. Okay, right, great. So I want to discuss briefly, before I ask Dr. Hayes a question, situations in which counseling about abortion is essential to a woman's health and safety. My colleagues on the other side would love to, are insisting that there's no legal basis for the interim and final rule that has been put forward. And if that is true, they don't want to see even counseling about abortion happening. But let's imagine a scenario that unfortunately is not so very uncommon. A woman with even a wanted pregnancy discovers that she has cancer. Her physician must be able to counsel her about the risks of chemotherapy to the fetus and talk with her about difficult choices to save her own life. Are my colleagues really suggesting that a physician shouldn't be able to convey life and death information to a veteran, a woman veteran, in this sort of situation? Again, a physician in this situation at the VA prior to this rule would not even be able to discuss this situation with a woman cancer patient who would definitely want to know whether or not certain medications and the chemotherapy would affect her health and even her life. A woman with a diagnosis of bipolar disorder is often prescribed lithium, a medication that can be very effective in treating symptoms that so often lead tragically to suicide. But this very same medication is toxic to a fetus and requires a long lead time to come off for the woman. It's not something you can just turn off and on. It's in the bodily system. Women in this situation may face difficult decisions about their own physical and mental health and the health of the fetus. And of course, they should be able to talk to a physician and a mental health provider. Other veterans diagnosed with depression are commonly prescribed medications like Prozac or Zoloft, which may be linked to a variety of birth defects. And women must be able to have important conversations with their doctors about these medications and risks to their pregnancies. The medication most often prescribed to treat epilepsy and other seizure disorders carries up to a 10% risk of causing a birth defect. Women with seizures therefore run the risk of having potentially lethal seizures without this medication or causing lifelong harm to a fetus. And I cannot believe my colleagues want to get between a woman and her physician. I could go on. There are several more examples of both mental health and physical situations where it is essential that that the government not get between a woman and her physician, a veteran woman and her physician, a veteran who's worn the uniform of this country, who fought for the freedom of all of us, is not able to get even life-saving, health-saving counseling. This is absurd. Dr. Hayes, you have served veterans tirelessly for decades. And one of the things you have had to do that we have only recently learned about is beg for life-saving care for veterans in the community because VA providers were not allowed to do so. In fact, they could not even talk to veterans about life-saving procedures. I understand that there are only a dozen or so of these cases a year, and my colleague, Chairwoman Brownlee, believes that there are more, and I believe I'm with her on this because counseling about abortion services that could save women's lives were not even permitted to be talked about, but there were brave VA physicians who put the life of our women veterans ahead of even their own potential livelihood. And I understand that there are only, so can you explain to the committee what these cases entail and what the frontline staff in your office have had to do to get women the help they need?
Chairman, yes, thank you for pointing out, I think, what are essentially often very tragic, stressful situations for a veteran who may require the kind of counseling that you outline in terms of having their own mental health provider involved. So we're looking at just exactly the kinds of very rare, actually, but very critical, life-threatening situations when someone has cancer, when someone later in their pregnancy, the pregnancy itself is causing a medical condition that the woman will die without the medical intervention. So it's a case-by-case situation. There's any number of medical complications that could make this happen. But when they do happen, we have to be able to find a way to have that woman decide what is her choice about this tragic situation. What does she want to have done? What does she want to do? And frequently that may involve her own mental health counselor who's been working with her to help her through those decisions. So it is the veteran at the center, and it is also the medical information that's provided about her life, about her health, about her mental health that will help her in coming to her choice.
Thank you, Dr. Johnson. Now we'll recognize Representative Rosendale for 5 minutes.
Mr. Chair, I don't have any more questions. Didn't have any questions. Again, this is the most pro-abortion administration that we've ever encountered. We know that they're going to support abortion at every option that they have. We know that they're going to take advantage of, unfortunately, the rulemaking process. I'm glad that the state of Alabama has already filed a lawsuit. I imagine there will be many other states that would join in. My hope is that they can be granted a stay so that we can keep this rule from even being implemented. What I would really had preferred is we had much more conversations about support for crisis pregnancy centers and adoption services and those types of things. I think the VA has taken it upon themselves to act as God and make determinations about which women are supposed to be giving birth and which ones aren't. And so they're going to be giving abortion counseling services to women at many times that have tried very hard to begin a family and would be quite offended to even hear this information. So I have no further questions for this panel.
Thank you, Mr. Rosendale. Chairwoman Brownlee, I recognize you for 5 minutes.
Thank you, Mr. Chairman. So, to follow up on Representative Frankel's questions around protection for community care providers, is this something that you've looked into and you know definitively that they wouldn't be protected under federal supremacy, or is it something that still, I'm not a lawyer, so is it something that could be looked into, that a change in the contract terms could protect them under federal supremacy?
Well, I'll just say that nor am I a lawyer, Madam Chairwoman, and so I think that is best offered back to you after this hearing for the record. What we looked into in terms of our options for that, and ultimately the determination we made that would be questionable, essentially based on the community providers needing to adhere to the jurisdictions of their states.
And because, in essence, this rule becomes effective immediately, correct?
Yes, Madam Chairwoman, effective as of publication in the Federal Register, with a period of public comment that we will strongly consider and certainly respond to.
Very good. So, and I think you said in your opening comments, or at least it was in your written comments, that a larger percentage of the abortions that would take place would be through medication abortions. Is that correct?
Yes, it is. That's what we anticipate based on our women's health team's analysis. If you'd like to speak to that analysis, Dr. Hayes or Dr. Johnson.
Yes, we anticipated about 1,000 abortions throughout the enterprise annually. The majority of abortions that are performed in the United States are first trimester abortions, and the majority of those abortions are medication abortions.
Very good. Well, I know that some of the, during the COVID pandemic, the VA worked with FDA to really expedite some additional drugs to be in the portfolio of drugs available to the VA. So I hope you will look at what they did there and replicate that to, to bring these drugs on board as soon as possible.
I will just say that we will, Congresswoman, be working with both the FDA and manufacturers of these drugs, and ultimately through our pharmacy benefits management program, make sure that we are complying with all of their rules in doing so.
Terrific. And I wanted to go back to the maternity care coordination. In my travels, I spent time in Oklahoma and in Texas and talked to all of the VA medical centers in every city that we've visited. And we talked to the maternity care coordinators within the VA. And, I think in some areas it was working pretty effectively, and others, it was very inconsistent, I will say, from medical center to medical center. But one thing that seemed to be consistent now, and I will say that both Oklahoma and Texas, if women are the largest growing cohort, they are growing exponentially in Oklahoma and Texas. So, and in all cases of every place that I visited, these medical care coordinators were handling 200 to 300 cases. It's a huge caseload. And some of them were only able to sort of meet with the veteran at the beginning of the pregnancy and maybe once after the pregnancy. Some were doing more than that. But I just think that we've got to take a hard look, to make sure that these maternity care coordinators are in a place where they can fully do their job and really be a partner to the woman who is going through her pregnancy, and can be an advocate, quite frankly, with a community care doc who is handling them. So I just, I bring this up because I think it is, with maternity care, it is all in the community. And, so we really have to have sort of full authority and be able to advocate for our patients who are out there receiving care. And with a caseload of 200 to 300, I think it's just virtually impossible to do so. So I will yield back with that.
Thank you, Chairwoman Brownlee. I would now like to dismiss the panel, the first panel. I want to thank you again for being here, and you're now excused, and we'll now move to our second panel. Okay. I now call up our second panel, and appearing before us today on our second panel is Dr. Ginny Ryan, who's with us virtually, Professor and Division Chief of Reproductive Endocrinology and Infertility, the University of Washington Medical Center, Montlake. She has earned degrees from several universities. Dr. Ryan was once named a Women's Reproductive Health Research Scholar, and comes with a plethora of knowledge on today's hearing topic. She does have to get to a surgery, so she will be testifying and will not be available for questions. Lindsay Church is a U.S. Navy veteran and is no stranger to this committee. As a strong advocate for veterans, Lindsay has testified before this committee on numerous occasions, and we look forward to hearing from Lindsay today. And we also have with us Kayla M Williams, Army veteran, and she is a senior policy researcher at the RAND Corporation. She recently served as the Assistant Secretary of Public and Intergovernmental Affairs at the Department of Veterans Affairs. She has also authored the memoirs, Love My Rifle More Than You, Young and Female in the U.S. Army, and Plenty of Time When We Get Home, Love and Recovery in the Aftermath of War. I want to thank all of our panelists for being here, and we look forward to hearing from you. I remind our witnesses to pause for 2 to 3 seconds before speaking and answering questions. And Dr. Ryan, I know that you have to get going soon. You are recognized for 5 minutes to deliver your testimony.
Thank you. My interest in veterans' reproductive health began with a study of 1,004 Midwestern women veterans that revealed an alarming 62% had experienced attempted or completed sexual assault. This trauma was associated not only with sexually transmitted infection and PTSD, but also with higher rates of infertility and postpartum depression. Most remarkably, 1 in 4 rape survivors reported they delayed having a family or decided against it because of their rape. Chairman Takano, Ranking Member Rosedale, and distinguished members of the committee, thank you for the opportunity to testify on behalf of my patients and their families. Thank you for the work you've done in the past to support our veterans' healthcare needs. My name is Dr. Ginny Ryan. I'm here on behalf of the American Society for Reproductive Medicine and in my capacity as a physician, researcher, and an ethicist. I'm currently the Division Chief of REI at the University of Washington, and I've worked since 2015 as a clinician and researcher at the Iowa City VA and the Puget Sound VA, and at times as a subject matter expert to women's health services. The views expressed in this testimony, however, are my own, do not necessarily reflect the official policy or position of the University of Washington, the VA, or the US government. In order to better understand the connection between trauma and later reproductive health, we followed our pilot work with a 5-year interview study of 3,018 women and men veterans from around the country. We found significantly higher rates of infertility in veterans than in community samples. Indeed, 2 in 5 women veterans and 1 in 3 men veterans trying to get pregnant were unable to do so after 12 months. Infertility seemed to be a particular problem for those with PTSD and more toxic environmental exposures during their service. And we are just beginning to understand all the elements of military service that may predispose our veterans to higher rates of infertility. It's become increasingly frustrating and concerning that the veterans I see suffering from this infertility are rarely receiving the seamless, comprehensive reproductive health care they need and deserve. I can find examples every week of patients exhausted and discouraged by structural issues and unfair rules that exacerbate disparities and inequities. I hope that hearing some of their stories will start us on a path towards bridging these care gaps. There's a quadruple amputee I cared for whose testicles were irreparably damaged by the IED that took away his limbs, and yet he didn't qualify for IVF or any fertility care for his wife because he didn't have any viable sperm remaining. There's a veteran couple who've successfully navigated the long path to IVF treatment, but then received multiple bills for their care and were sent to collection, which impacted their credit score and their ability to buy a home. There's a veteran I saw just last week whose trans woman partner's sperm counts are diminished due to gender-affirming hormone therapy, forced to pay for and use anonymous donor sperm rather than having a fully genetically related child through IVF because gender incongruency is not a service-connected disability. And there is every woman whose polycystic ovarian disease or endometriosis or fibroids or tubal infection went undiagnosed during their military service, leaving them unable to access the full spectrum of infertility care they need because they were not disability related for these diseases during VA enrollment. And every veteran whose lifetime trauma has caused incompletely understood effects on their ability to have children, leaving us unable to treat them. Infertility is a disease, and just like for any other disease, the VA should provide access to full spectrum care without restriction. As has been mentioned multiple times, women of reproductive age are the fastest growing subset of new VA users. And for many, such as those whose stories I've shared, the ability to become a parent hinges on access to IVF and care for their non-veteran partners. Current restrictions to this access are discriminatory, unnecessarily complex, and onerous. And they ultimately perpetuate the status quo of inadequate reproductive health care for women veterans. I am also deeply concerned as a reproductive health provider and former abortion provider that accessible abortion care is not a part of reproductive health care at the VA. Abortion care is reproductive health care, and every person should have the right to decide whether, when, and how they become a parent. This is vital to showing our veterans the respect they deserve and helping them and their families to flourish. No veteran should have to cobble their reproductive health together piece by piece, not knowing where they can access which aspect of their care legally, affordably, and without judgment. Every patient and their story stays with you, but the ones you remember longest are those you wish you could have helped more, had services been more available and systems more functional. Today, you all have the chance to help us help our patients by removing the roadblocks they face. Our veterans know what they need to survive and thrive, and we are here as researchers and healthcare providers to listen to them and get them what they need with your support. So thank you again for this opportunity to testify, and thank you for taking steps towards better serving our veterans who have given so much to this country.
Thank you, Dr. Ryan, and I wish you well on the surgery you need to perform. So thank you. I'm sorry you can't be with us to answer questions. Your expertise would have been, I think, greatly enlightening. I now turn to Lindsay Church. Lindsay, 5 minutes.
Chairman Takano, Ranking Member Rosendale, and members of the committee. My name is Lindsay Church, and I'm a third-generation veteran of the United States Navy. I served from 2008 to 2012 as a Persian Farsi linguist. I've appeared before this committee before as the Executive Director of Minority Veterans of America. I'm here today to share my personal story. As a veteran and military child, I'm no stranger to sacrificing for the greater good. In uniform, it was my duty to protect and defend the Constitution of the United States. I served as a queer person under Don't Ask, Don't Tell, and understood that there were some rights I wouldn't enjoy while serving, but that I would be afforded when I became a civilian. Among them was the right to an abortion and to live a safe and healthy life as a queer person. During my service, I experienced complications of a birth defect that caused my sternum to be severely inverted. As a result of a failed corrective surgery performed by Navy doctors, I've had 9 surgeries on my rib cage and spine, and missing 36 inches of ribs and all of the cartilage of my chest, was hospitalized for nearly 60 days and have a spinal cord stimulator that controls my pain. After my 6th surgery, I had to face that my physical disabilities meant I couldn't carry a child. I was medically retired in 2012 and have received care through VA's women's clinics for the past 10 years. Last year, my wife Jess and I began planning to start a family. We were excited and nervous, but it was clear we couldn't turn to VA for support for 2 reasons. First, VA offers fertility treatment to veterans when it's caused by a service-connected disability, but only some, and mine didn't qualify. Second, we're in a same-sex marriage, and VA limits IUI and IVF to legally married veterans with opposite-sex gametes. In spite of it all, we began our journey to starting a family last fall. We worked with a fertility clinic and developed a care plan, most of which we paid for out of pocket. In April, we attempted IUI for the first time. While waiting to learn if Jess was pregnant, the draft Supreme Court opinion in the Dobbs v. Jackson case was leaked. 4 days later, we learned Jess was pregnant and celebrated the happiest and scariest moment of our lives. The decision in Dobbs was delivered on June 24th. 2 weeks later, we learned during a routine ultrasound our child's abdomen was distended to the point of concern. It took 33 days and into Jess's 16th week of pregnancy to get the tests we needed to understand that our child had a fetal bladder deformity and couldn't produce amniotic fluid. Through it all, we felt like we were racing a clock. We knew the day we had to make a decision or we may be forced to leave the state to get an abortion. The moral injury of having served a country to protect a constitution that no longer protected my family when we needed it most was absolutely devastating. We made the most painful and most compassionate decision for the child we loved so much to end the pregnancy. We wanted our baby more than anything in the world, but we couldn't imagine a life where all they knew was suffering. I was born with a severe genetic deformity, and I couldn't imagine this life for them. At Jess's pre-op for a dilation and evacuation procedure, we learned our baby had no heartbeat and had passed days prior. The procedure for a second trimester miscarriage was the same as it was for an abortion. The only thing that changed was the urgency for care. She accessed care not through CHAMP VA or TRICARE, which Jess qualifies for, but through a community-based clinic in Richmond, Virginia. She accessed care because state insurance covered the procedure, we had non-VA providers, and we live in a state that didn't restrict access. VA's new reproductive health services policy will allow veterans, family members, and caretakers to access abortion counseling and abortion care in the case of rape, incest, and when the pregnancy threatens the life or health of the patient. This policy will save lives. It'll save the lives of veterans and families across the country living in states that limit or completely ban abortion. Were it in place 1 month earlier, my family could have turned to VA for care. For the policy to serve the veterans who are most likely to need access to care and least likely to have it, including racial and ethnic minorities and those living in poverty, it's imperative that Congress pass comprehensive national policy to protect abortion and other reproductive health services. Finally, as I mentioned earlier in this testimony, I've received nearly all of my care through VA for 10 years. For a decade, I've navigated a health system that's unable to see, understand, or serve veterans like me. I expect that if I choose VA for care, I'll be consistently misgendered, treated like I don't belong or don't matter, and I won't be safe in VA facilities. Last year, I was harassed by a Richmond VA staff member while using a women's restroom. It wasn't the first time I've experienced VA harassment, nor was it the last, but it was what pushed me to finally seek care outside of VA. I'm one of many veterans leaving VA because the department isn't equipped to provide positive patient health experiences to women and gender minority veterans. From mottos to pronouns to bathrooms, many fear using VA because it continues to be traumatizing. No one should have to endure what we do for healthcare. Thank you for the opportunity to testify. I look forward to your questions.
Thank you, Lindsay Church, for that very moving testimony. I now call on Ms. Williams to deliver her testimony, 5 minutes.
Chairman Takano, Congressman Rosendale, distinguished members of the committee, thank you for the opportunity to discuss women veterans' access to the full spectrum of medical care, including reproductive health care. I'm testifying today as a senior policy researcher at RAND. I also formerly served as director of the Center for Women Veterans at the Department of Veterans Affairs. And I am also a VA patient. I choose to get comprehensive and integrated care from a patient-aligned care team at VA, where my healthcare providers understand my military-specific risks and exposures. Among women veterans using VA healthcare, 43% are of reproductive age, 18 to 44, and to meet the fundamental healthcare needs of women veterans, it's important for VA to provide the full spectrum of reproductive healthcare. On July 1st, 2020, I testified before the HVAC Subcommittee on Health about this topic, recognizing VA's areas of strength, while also noting that there were deficits related to provision of in vitro fertilization, contraception, and abortion. Since that time, VA has announced significant changes in its provision of equitable, life-saving care, on which I will focus my remarks today. The recent Dobbs v. Jackson Supreme Court decision overturned the constitutional right to abortion. This ruling will limit some women veterans' access to the full scope of reproductive health care, as those living in many states will no longer have access to abortion care in their communities. This could have a direct impact on their health, since abortion can be medically necessary. The interim final rule on reproductive health services that VA published last Friday supports women veterans' access to needed abortion treatment by removing the exclusion on abortion counseling from the medical benefits package and allowing enrolled veterans to obtain abortions if determined needed by a healthcare professional when the life or the health of the pregnant veteran would be endangered if the pregnancy were carried to term or the pregnancy is the result of an act of rape or incest. While not expansive enough to cover all situations in which abortion could be beneficial for enrollees, this rule will protect the lives and health of vulnerable veterans. VA estimates that 72% of current veteran VHA users who are capable of pregnancy have a service-connected disability of 30% or higher. They have high burdens of chronic disease and a significant rate of mental health conditions. Some of these are associated with worse pregnancy outcomes. Women veterans with PTSD, for example, are more likely to experience gestational diabetes, preeclampsia, and preterm birth. Accordingly, it is exceedingly important that they be able to access the care their providers deem to be medically necessary. Recent restrictions on reproductive health care at the state level mean that women veterans in certain states are no longer able to access such care from non-VA providers. Therefore, to ensure optimal health outcomes for women veterans, VA must be able to provide that care. Although all states have exceptions for the life of the mother, and most allow abortions for the woman's health, restrictive abortion policies are having a chilling effect that can delay needed care, including treatment for cancer. Providers in some states may face prosecution and jail for providing abortion treatment and may delay or deny needed health care for pregnant women given these risks. Access to medication needed for other services can also be affected, as pharmacists are reluctant to fill prescriptions for drugs that can have multiple uses, including but not limited to medical abortions, such as managing miscarriage or treating chronic disease. VA's interim final rule allows veterans to access care their VA providers determine is necessary to promote health or protect life. It is also important that VA be able to provide these services directly because VA provides high quality, evidence-based, culturally competent care. For example, VA trains providers to provide trauma-informed pelvic examinations for women veterans who have experienced military sexual trauma. In addition, fragmented care can lead to worse health outcomes. Ensuring VA is able to provide the full spectrum of reproductive care to vulnerable pregnant patients is an important part of comprehensive and integrated care. In conclusion, veterans and beneficiaries who need abortion counseling and covered abortions will benefit from being able to receive these services within the VA system, optimizing their continuity of care and access to needed support. Thank you again for inviting me to testify before you today on this important topic. I look forward to answering any questions you may have.
Thank you for your testimony, Ms. Williams. I will now recognize myself for 5 minutes for questioning. Lindsay, in your testimony, you outline how current reproductive assistance through VA is exclusively offered to heterosexual couples. Can you talk about why access to reproductive health care for services for all gender identities and sexual orientations is so important to veterans?
Thank you for your question, Chairman. As an LGBTQ person, we as a community are required to look to the services such as donated sperm. IUI, IVF to be able to actually have children. And so being able to access this service as a queer family will empower us through the only method that we're going to be able to start a family. My family was fortunate in the sense that we were able to pay out of pocket, but there's so many folks in the community that don't have those resources. Much of the queer community experiences economic barriers, housing, employment, that continue to make their experiences around family planning multifaceted, and VA has the opportunity to step in and provide hope to our community, especially folks that can't prove their service connection. As I mentioned, I'm one of many people that can't prove service connection to be able to access those benefits, so removing some of those regulatory bars will offer us hope.
Well, I'm someone who believes that service connection should not be a reason it should not be predicated. We should not predicate the availability of reproductive services. The full array of reproductive health, including the fertility, in the big scheme of things, is not cost prohibitive. Very few veterans are going to encounter that. And as you said, you had the ability to pay out of pocket, but typically, I would say a big share of our veterans that use the VA system are low-income people. I think Ms. Williams, can you comment on that? The type of women, the veterans that use our system, or veterans in general, tend to have limited incomes.
Research has shown that VHA users tend to be of lower socioeconomic status than veteran non-VHA users. So yes, that is correct.
And so a veteran that needs reproductive health care, fertility services, and who might need IVF, veterans are essentially deprived of access to fertility services. And I think most Americans would be outraged that people who've worn the uniform of our country and who may have difficult to prove connections that their infertility is connected to their service, that we should just give them the benefit of the doubt, like we've done with the PACT Act. We give the veteran the doubt and don't deny them services such as fertility services so that they can have children. I think most Americans would say that is the fair thing to do. I don't know. I mean, do you wish to opine on what I just said?
I will just note that when my spouse and I were struggling with infertility, it was we were unable to access fertility care either. And at that stage in our lives, we were unable to afford it. And so from a very personal perspective, I do agree that anybody who needs to be able to access needed care to expand their families should have that opportunity.
Lindsay, you look like you wanted to say something.
I did. Service members give their reproductive years, the best years of their lives a person that retires out of the military is going to give 18 to 38. By the time, and outlined in Dr. Ryan's testimony, actually included stories of service members, women veterans who flew helicopters for this country and made sure that we were staffed at war, came back and then were too old to be able to access care or be able to start a family naturally. They should have access. If you give your years of fertility to this country, you should be able to access those benefits after the fact.
Thank you for bringing forward that example. And let's understand that the 170 members of this Congress, all of them of the other side of the aisle, and including all of the members of this committee who are the Republican members of this committee, save one, have signed on to H.R. 1011, which would make access to IVF impossible, would make it illegal. I think most Americans would say that's extreme. And I would say it's unpatriotic. I would say it's unpatriotic that we would deny that fertility opportunity to the men, to the women, the men and women, actually it applies to men too, men and women of this country who've worn the uniform of our country. I now will call on, recognize Representative Rosendale for 5 minutes.
Thank you very much, Mr. Chair. I'd just like to start off by saying that the continued proclamation by the pro-abortionist witnesses today that the Dobbs decision, which was recently decided by the Supreme Court of the United States, overturns the right, the constitutional right to an abortion, is false. And your continued use of that statement doesn't make it so, unfortunately. It might make the evening news, but it doesn't make it so. Ms. Williams, if I heard correctly, even after the Dobbs decision, okay, has been released, if a mother's life is in danger, she will still be able to receive the standard of care to save her life under the laws of every state. Isn't that correct?
It is my understanding that while the right may be there, many providers are so concerned that they are hesitating.
I have lots of anecdotal information. If I heard you correctly, I'm going to just go ahead and do it. I mean, you answered, but I just want to just cut it off right at the answer. If a mother's life is in danger, she will still be able to receive the standard of care to save her life under the laws of every state, correct?
In terms of the standard of care that is acceptable,
To save her life.
the laws do not prevent saving a woman's life.
The laws do not prevent a medical professional from saving the life of any woman, correct? Are you telling me that the medical industry, okay, cannot go out under any circumstance, have an accident on the highway, you're in a hospital, whatever it is, that if a mother's life is in danger, she will still be able to receive the standard of care to save her life under the laws of every state?
Sir, I'm sorry, you phrased that in
Could
a
you,
slightly
let me ask it a simpler
confusing
way. Could you tell me a single state that's going to prohibit saving a mother's life?
Sir, I at no point said that.
Yeah, okay. You testified that abortion bans are having a chilling effect on providers who would be the ones who provided this care. It seems to me that the pro-abortion discourse is instrumentally conflating standard of care with elective abortion. Not a single Republican here opposes care for mothers whose lives, unfortunately, are threatened. But all of us oppose abortion. Conflating the two is irresponsible fear-mongering. And I would suggest that the pro-abortionists consider that if they are concerned about this chilling effect. So, Mr. Chair, earlier you stated that you don't believe that the services should be predicated on service-connected disabilities. And Lindsay, you stated the same thing. And Ms. Williams, I guess you probably feel the same way. The problem is that we have laws in this land. And while you all may have opinions about what services should be delivered and when they should be delivered and who they should be delivered to, we have guidelines, we have laws, and it's based upon service-connected disabilities. So this is what all of these hearings are about today, and that is that the Veterans Administration is trying to bypass those very laws and use the rulemaking process to be delivering services that the law specifically prohibits and calls the taxpayers of this nation to be paying for them. And that is what our job is. That is what our job is. So, Mr. Chair, with that, I would yield back.
Well, thank you, Mr. Rosendale. I'll remind you that I believe that you are somebody who's a co-sponsor of H.R. 1011, which would, in fact, if passed into law, prohibit life-saving procedures for women who have a life-threatening pregnancy. I repeat, what you're saying is with regard to certain state laws, may be true for a woman who's in active emergency and actively dying. But make no mistake, many of these states that have prohibited abortion and narrowed the exceptions for when abortion might be permitted, do not attend to women who are at risk of dying or of disability. And remember that VA could not even counsel a woman about life-saving procedures prior to this interim and final rule. They could not even do the counseling. So I now recognize Ms. Brownlee for 5 minutes.
Thank you, Mr. Chairman. And just while we're on this topic of IVF and fertility, I just want to put in my 2 cents on it as well. And, fertility is a medical condition, full stop. And just like everything else, every medical condition that the VA, serves veterans for their health care, infertility is just a condition. And it is also very, very hard to accurately diagnose the cause of infertility. And currently, the VA addresses infertility and treats women and men for their infertility throughout the VA. And many times they are successful in treating that. But when you get to a place where all else fails, then IVF is the only option. And so it is abundantly clear to me that we need to treat this as just a part of our healthcare services, and infertility is like cancer, is like appendicitis, it's like anything else. It needs to be addressed by a medical facility and a medical provider. So I just wanted to add that. I think, Mixed Church, your testimony, thank you for sharing your personal story. I know it's not easy. You come and testify and are advocating for veterans all the time, but not sharing your own personal life in it. So I thank you. It takes a lot of courage to come forward and do that. So I guess my question to you is, what can the department do to make the VA a more positive environment for gender minorities, women, and LGBTQ plus veterans?
Thank you for your question and your kind words. Thank you. From my perspective, VA has to take this as the large and the small. Large cultural symbols like the motto emblazoned on every single building isn't helping anybody feel more comfortable. In fact, it might as well say we only serve men here. Our communities need access to care, and every time they walk through a facility, they're denied the belief that they understand them. So while it doesn't seem significant, if we can't even start with a motto that's not exclusionary, then we're on a bad place. Second, it's the small things. It's also like training and education, and not just saying we have training and education, but mandating it. Bystander intervention that doesn't also harass trans people would be really awesome. Facilities should be safe. We shouldn't worry about what bathrooms we go into. We shouldn't worry about very necessary functions. I was on my way to get an x-ray, and all I needed to do was use the restroom. So training and education that's not just offered, but mandatory by every VA employee on women, gender minorities, the broader community, and understanding who we are. It's not controversial, it's just better care. And then the last is, I think it was Representative Pappas that was talking about data collection, asking questions about where that data is being collected. I can honestly tell you that it's not being collected correctly. My wife had to give a pronouns conversation to the patient advocate, who is one of the reportable folks at the facility that I should be able to go talk to. Who am I going to tell? So it's the big things and it's the small things. It's about culture that sees us, recognizes us, and centers us when building care and facilities and everything that they're doing.
Thank you very much for that. And Ms. Williams, you know, in your testimony, you really sort of built a very strong argument why abortion counseling is really important. You talk about the fact that VA users tend to be sicker and lower socioeconomic status. You say that women veterans who use the VA have high burdens of chronic disease and a significant rate of mental health conditions. And you go on to say that, you know, pregnant women veterans have extremely high rates of depression and often discontinue medications for this and other conditions. And I agree with you. It's very important to have abortion counseling where the woman and her doctor can talk about, who knows their condition and can talk about what their options might be and what their risks might be. But do you also think that because of those factors amongst our women veterans that the likelihood of more life-threatening situations will occur that may indeed require an abortion to save one's life?
One reason that I think it's important that VA be able to provide this care is to be able to collect that type of data. If VA is unable to know about the full scope of reproductive health care that women veterans may require, if women veterans, pregnant veterans are seeking care, this type of care in other settings and may not be communicating that back to their providers, we may not be able to ever truly know the answer to that question by having the data required to track it thoroughly. And so I could guess the answer to your question, but I would rather be able to come back and tell you in 5 years.
As a data-driven person representing a data-driven organization, yes, I do understand. So thank you for that. But I also want to add just on this argument about, you know, all states will provide abortions in the event of a woman's life or death. You know, and again, we don't have the data on this, but we hear anecdotal stories, and I've heard anecdotal stories within the VA as well, that women will come and have a condition, you know, she may be bleeding out of some sort or whatever, but will get stabilized. Doctor will send that woman home and wait until it is, you know, it becomes an emergency, and then under those conditions may be treated to save her life. But the physician knowingly does this, sends her away knowing that the eventuality of all of this is she's going to be back and her life is going to be threatened and she will need to be treated. That's just, it's unacceptable. I mean, it's just absolutely unacceptable. So it is, again, I just, you know, I thank the VA for taking these steps and moving forward. And without a doubt, lives are going to be saved without question. And that's the least of what we can do to service our women. And I will just close out here by saying that I wanted to just, you know, thank Dr. Hayes for all the work that you've been doing and continuing to do. And I know this has created a lot of work for you in your office. And I know you're working around the clock to make all of this happen and to have clarity across the country with regards to this new rule on the VA. So I just, you know, I really do thank you. I've enjoyed so much working with you over the years as we have worked together to better serve our women veterans, and I just thank you for all the hard work that you continue to do. And with that, I will yield back.
So thank you. I am going to do one more round of questions. And so, Ms. Williams, I want to give you some time to respond more fully to the questions that Mr. Rosendale asked you about. I mean, I quibble with his assessment that states will allow, you know, always, in all cases, you abortions in a life-saving situation. Let's talk about, you were on a train of thought when you said a chilling effect. Can you explain more what you were thinking about the chilling effect that various state laws have had, and what you were about to say?
I think that your colleague, Representative Brownlee, also talked a bit about this and the fact that providers can feel so strongly the need to be confident that it is an imminent risk, that they may delay procedures to a point where there could be other effects to long-term fertility, for long-term health. And I personally really strongly believe that we should be able to rely on the expertise of our healthcare providers and trust that they are going to be able to make decisions based on what is in the best interest of our health and our life, and not on what their fears are of whether or not there could be consequences to them beyond focusing on health and life. And if I may be so bold as to also share, I mentioned that we had struggled with infertility in the past. We went on to adopt our son. I then eventually did give birth to my daughter. I have also lost a pregnancy to miscarriage and needed medication very similar to that used for abortion to pass the product and prevent sepsis, which would have caused serious problems in the long term and possibly threatened my life. I also went on to donate a kidney to a stranger. And I want to just note that my belief in the inherent dignity and life of all people is very deep and unwavering. Thank you.
Well, thank you, Ms. Williams. And as I said in my opening statement, women veterans such as you and Lindsay fought for our freedom and fought for women's freedom to be able to make choices in protection of their own health and in the interest of their own health and life, and also for the freedom of medical professionals to be able to exercise their best judgment and to use their knowledge. I don't believe the government or politics should get in between medical providers and their patients, women veteran patients. And so I thank you very much, both of you, for your courage in your testimony and sharing your personal experiences. And I may just want to ask you also about your research that links PTSD diagnoses to higher risk of pregnancy complications like preeclampsia and preterm birth. Can you walk us through how VA's new regulation will help improve the quality of care for veterans with mental health diagnoses, such as PTSD?
Let me be very clear that I, unfortunately, am not skilled enough to have done that research myself. I'm citing other research by fantastic medical professionals who are much more qualified to do that specific type of research. But the hard work by these highly qualified VA providers has shown that PTSD diagnoses are associated with these negative outcomes. And preeclampsia can lead to eclampsia, which is, in fact, a very life-threatening condition. That's why it is so important that VA providers be able to counsel their patients on risks and be able to make the right decisions about what kind of care to offer them if they do reach a stage where where abortion may be needed to promote health or protect life.
Well, thank you. Ranking Member Rosendale.
Thank you, Mr. Chair. Just a little comment. When you have health care that is provided by the government and funded by the taxpayers across this nation, the reality of it is that Congress makes the decision about what is and what is not covered. That's how it works. Whether you're talking about Medicare, whether you're talking about Medicaid, or whether you're talking about the Veterans Administration, that's just the way it works. And while we had some anecdotal stories and some fears that one might experience, what we have not had is a single example of a state that would cause the VA or any facility to prohibit the standard of care that would save the life of a mother if it was in jeopardy. No one has been able to state that. And in regards to the Veterans Administration, Congress has made the decision that care will be delivered when there's a service-connected disability. Congress made that decision. No different than we all got together this year and we passed the PACT Act. And I'm really pleased to have been able to support that, okay? We made the decision to make that investment. But when it comes to health care delivery, Congress has to go through that process. And so until they do, what we are witnessing today is a complete disregard for Congress and the rule of law. So with that, I yield back.
Well, Mr. Rosendale, I just have a simple disagreement. The 1996 law that Congress passed empowered the Secretary to define the benefit package for VA. Therefore, the benefit package that has been set forth in this interim and final rule is rooted in law, is rooted in statute, and is rooted in congressional action. I now recognize Chairwoman Brownlee.
I'm going to change the subject a little bit. So, Ms. Williams, my question I wanted to ask of you is really sort of through your research, you've done a lot in terms of shedding light on both the challenges experienced by women veterans accessing care and the importance of a smooth military to civilian transition for all veterans. So trying to merge those two component pieces together, and if you could share with us what you think are ways in which we can better support our women veterans and our women's veterans' health as they transition from the military to civilian life, and what we could be doing better.
In terms of supporting the transition of women veterans, I think that the program that started out as a pilot to provide women-specific TAP and has now been expanded nationwide is a incredibly positive development in being able to support that transition, ensure that women veterans know about the full scope of healthcare that VA is able to provide, because so many veterans don't know that VA provides the maternal care coordinator program, for example. And when I think back of how much I spent on pumping supplies, to know that VA provides free breast milk storage bags, free nursing bras, free nipple cream. I mean, these are things that are incredibly helpful. And for transitioning service women to know that they can go to VA and get that level and standard of care is incredibly helpful. And it's also beneficial for them to be able to know that they can expect the same standard of care now within VA that they could in DoD. If, for example, they have experienced a sexual assault and leave the military, previously they would have been able to expect abortion care in DoD, walk out the door, enter a VA facility, and not be able to access the same level of care for that traumatic event. And for them to be able to be informed that they will be able to expect the same level of care within the Department of Veterans Affairs, I think will also help give them the comfort to know that they can enroll in VA and expect that high quality care. Should also support them in their transition and their willingness to come to VA. And coming to VA is important because we know that the quality of care is high, that VA providers have more cultural competence, especially on military-specific issues, such as the PACT Act that's been mentioned today, big expansion. And we want to make sure that women vets are coming to get this evidence-based care, this culturally competent care, this high-quality care that they have earned through their honorable service in the Department of Veterans Affairs.
Thank you very much. I have no more questions, Mr. Chair.
Thank you. I'd like to ask, thank you very much, Chairwoman Brownlee. I'd like to ask Ranking Member Rosendale if he has any closing comments.
Thank you much, Mr. Chair. I appreciate it. I'm distraught today. as we listen to the Veterans Administration attempt to justify using a rulemaking process to completely disregard the rule of law that people have relied upon for years, which prohibited abortions, abortifacients, and abortion counseling services by the Veterans Administration and paid for by the American taxpayers. It's clearly an overreach by the Veterans Administration, and a lawsuit has already been filed. I'm hopeful that the courts will overturn this rule, and I hope that they're able to obtain a stay so that this rule is never implemented. Thank you, Mr. Chair, and I yield back.
Thank you, Ranking Member Rosendale. I should have thanked our panel before I recognize for final comments, but thank you very much, both of you, for your service to our country, for your courage in sharing your own personal experiences, as well as your expertise. And I'd like to excuse the second panel, and I will now go to my final statement. Let's be clear that the rule that the acting ranking member seeks to stay and hopes will be stayed would return us back to the days, not, I mean, just when I say days, it's just a week ago before this rule took effect, when VA could not treat 4 life-threatening conditions when an emergency abortion may be necessary. This is what my colleague, acting ranking member Rosendale, would seek to do. VA, prior to this rule, could not treat severe preeclampsia early in pregnancy. It could not treat heavy bleeding leading to a hemorrhagic shock. It could not treat placental abruption causing hemorrhage. It could not treat water breaks early in pregnancy causing infection. And it could not treat ectopic pregnancies. These conditions, by the way, could be treated at a Department of Defense medical facility. They could be treated in a federal prison for women who are incarcerated in federal prisons. But for the women who wore the uniform of the United States of America, who again, I will say, fought for our freedoms, they could not be treated for these 4 life-threatening conditions when an abortion may be necessary. To me, this is an insult to all the women who've worn the uniform of our country, and I thank Secretary McDonough and President Biden for standing up for the women who have served our country proudly. And I thank all those women who served our country and put their lives at risk for all of us. And we now have a step forward in having their backs and offering them the care that they deserve, that I believe the American people will agree that we should not be hoping for a stay, that we should be hoping for an affirmation that this rule is very much necessary, is very much fair, and it is time that we afforded our women veterans the same level of care that our active duty service members receive and the women in our federal prisons receive. So with that, I will adjourn this hearing and thank every participant today. And all members will have 5 legislative days to revise and extend their remarks and include extraneous material. And again, thank you for appearing before us today. This hearing is now adjourned.
Have a great weekend.
You too.
Okay.
Thanks.
Travel safe.
Okay, thank you.
Thanks, everyone.